All right, so we're going to continue on down the respiratory system. This is in the lower respiratory tract, talking about the trachea. Another common term or name for the trachea is the windpipe. And remember, the trachea has those C-shaped cartilage rings to keep it open, because we always need to be breathing. So even when we're sleeping, there's the trachea held open by this C-shaped or horseshoe-shaped ring of hyaline cartilage. So that's what's shown here. And then as we work our way to the inside, we have this tissue that lines the inside of the trachea, which is the ciliated, you can see the cilia there, pseudostratified, which means it looks like they're piled on top of each other, but they're not, columnar epithelium. So this is the layer, ciliated, pseudostratified columnar epithelium. And then there's goblet cells kind of mixed in there for producing mucus. And these little white structures here in the submucosa are also little glands that secrete mucus. So lots of protective mechanisms as we work our way down into the lungs. Before we get there, we have cilia lining the airways, lining the trachea. We have mucus, which traps debris. And then the cilia moves that mucus toward the esophagus, right? So, or the larynx, so we can cough it up and out if necessary. If you have a really bad cold, you don't want to swallow all that stuff. So we cough it up and out, or we just clear our throat a little bit and go, and then we swallow it down. So if our cilia are working properly, again, chronic exposure to cigarette smoke damages the cilia, and that debris and mucus end up working their way down into the lungs. So people have deeper coughs, it's down in the bronchi, and those people end up with bronchitis, and also with excess mucus, infections in the airways. So not good for the mucous membranes of the trachea. So at the bottom of the trachea is a special structure, and this was also in your lab objective, so be sure you know this for lab. This is at the base of the trachea, right before it divides into the two bronchi. It's called the carina, and the carina is highly sensitive, so it's an area of the mucous membrane. The different textbooks describe it differently, but it's right at the base of the trachea before it divides into the bronchi, and it has lots of sensory receptors. So if food or water would hit that, it causes a violent coughing response. It's the kind where maybe you've had it happen to yourself, where you've got a little saliva, or you take a drink of a soda or water and it kind of goes down too fast, and then you're violently coughing, where you have to like excuse yourself if you're in a quiet environment. You kind of turn red, right? And we see that in our patients. I think did I talk about that last time? That if you're giving a sip of water to a resident and they're coughing, that's a sign of poor swallowing ability, and that needs to be evaluated, or they're going to be getting pneumonia. It's just a matter of time. And I had a patient, I worked yesterday, and I had a patient with exactly that. And I wrote up in the chart that he may need a swallow study, because that is not normal to be coughing after sipping water. And when you're trying to give patients their pills, in order to swallow those pills, they got to follow it down with water. So what do we do to help those patients, do you know? Thicken the liquids so they get their hydration, because this gentleman was very dehydrated as well. I mean, he was getting fluids, but not much. But his urine was very concentrated because he didn't want to drink water because he was coughing. He had a hard time swallowing. And what do you think the number one cause of swallowing difficulty is? What do you think he had in his medical history? No. Affects the nervous system. Old people get clots in the brain that kind of damages the nervous system. Stroke, yeah, so he had a stroke. So stroke patients are really at risk for swallowing problems. So anyway, we have the carina to protect the airways, but if it's a chronic coughing problem, then that protection level is reduced. So let's see. Okay, so the bronchial tree. So once we get beyond the trachea, then we're down into the bronchi. So these large airways where the trachea divides. So the carina would be right here, right at the base of the trachea. Then it divides into the bronchi. And if you notice, the right bronchus is more vertical and it's wider than the left bronchus. So when someone chokes, they're more likely to get that food particle stuck on the right bronchus than the left bronchus. And if it's really bad, sometimes they have to go down with a long, I don't know what the name of the tool is, but like a long grabber, whatever it's called, go down there and pull that piece of food out. And what's really sad, I was reading a story about a a healthcare worker that works in a developing country, kind of on a mission project. And a young child passed away simply because that clinic didn't have the money for a pediatric tool to remove that lodged food, and the child died. So such a shame that, you know, something so that we would take for granted here in the United States, that child lost his life because of that. So the conducting zone is just where we go from the trachea to the terminal bronchioles. So it's just all the airways. So this is really a cool picture here. This is from your textbook. It just shows how those airways branch and branch and branch till we get down to the tiniest of airways. So cartilage holds the system open near the top portion of the conducting zone, and when we get down to the tiniest of bronchioles, it's smooth muscle that holds those airways open. So that's where it becomes problematic in people with asthma, is they have a reactive airway and that smooth muscle constricts because of an allergic response, and then they have trouble moving air. And that's only down in the bronchioles because the trachea holds everything open everywhere else. So the respiratory zone is when we get down to the alveoli, and we have the bronchioles here. The terminal bronchioles is the last bronchiole before we end into the alveolar sacs here. So these are the alveolar sacs. So the passageway within an alveolar sac is called an alveolar duct, and here's where the gas exchange occurs. And we talked about the tissue in lab. What is the tissue type that makes up the alveoli, which are very thin, fragile tissues for rapid gas exchange? What's the tissue type there? Yeah, simple squamous, one layer of flattened cells, because when we get that oxygen in there, we need to get that out of there quickly into the blood. So it's a very thin thin wall on the alveoli to get that good, efficient gas exchange. And then wrapped around those alveoli are these lovely capillaries. And capillaries, if you remember from the blood vessel unit, are also simple squamous epithelium. So you have two simple squamous epithelial cells right next to one another. One is part of the alveolus, the other one is part of the pulmonary capillary. So it's not too far for that CO2 and carbon dioxide to diffuse across to get it from lungs to blood or blood to lungs. So it's a very well-designed system. And we call that relationship between the pulmonary capillary and the alveolus the respiratory membrane. So if on a test we asked you which of the following makes up the respiratory membrane, it would be the pulmonary capillary and the alveolus. So if I look at the alveolus, you can think of it like a soccer ball, in that we have these flattened simple squamous cells that make up the soccer ball. And then there's two types of alveolar cells. There's type 1 and type 2. The type 1 cells are kind of just like the brick and mortar of the alveoli. They just form the structure of it. And the type 2 alveolar cells, shown in green here, they produce a special substance called surfactant, which is a special protein that helps break down the water molecules in the lining the alveoli, because water wants to stick to itself and form a water droplet. And you have these tiny, fragile alveoli with this water lining, which is good. It keeps it moist and elastic, and it's good for the health of the tissue. But if we get too much water in there, the lungs collapse because it forms a water droplet. The water molecule, for example, on this side of the alveolus will be attracted to the water molecule on this side, and it'll close this alveolus. So surfactant produced by the type 2 alveolar cells breaks that down. Just like if you would use dish soap to clear up a pan with beads of grease from making bacon, for example, it breaks that cohesiveness from those molecules down. So think of it like a soap product with a greasy oil. It breaks that water molecule droplet down. So we can improve surfactant production by deep breathing. When you deep breathe, you expand your alveoli, and that stimulates surfactant production from these type 2 alveolar cells. So what does that mean when you have a patient that's sitting in their chair or their bed like this, sleeping, and they're on a bunch of narcotic pain meds? So their respirations are really low. What are they at risk for? Pneumonia and lung collapse. So what happens is, and this happens in a lot of patients that are just sitting in bed sick, they get tiny little collapses in the base of their lungs, because if they're not taking deep breaths, they're just breathing kind of in the upper airways. They're not expanding those alveoli, and then they start to collapse. And then they have reduced gas exchange. And when you listen to their lungs, it sounds diminished. They're not, getting that nice big flow of air. So what do we give to patients that have had surgery or have some respiratory issues while they're sitting in the hospital? Yeah, an incentive spirometer. And I'll show you what that looks like for those of you that aren't familiar with the hospital scene. And if some people have been in the hospital like multiple times because of chronic conditions, they probably have 20 of these sitting at home. And they always say that, oh my gosh, I've got a ton of those. So that thing there, incentive spirometer. So you have them inhale and it raises this little white disc up, and then they set this yellow bar to where their goal is, or where they last attempted and where they were at, and they try to beat that goal. And we always have them take a couple of deep breaths first before they try this, because just doing the deep breathing expands the lungs and they'll perform better. So that's the incentive spirometer. So we really want to keep our patients deep breathing and getting those lungs expanded. And even yourself, when you're taking a test or you're anxious, driving in the car thinking about, oh my gosh, I have a test today, right? We tend to breathe shallow when we're anxious, and especially taking a test. So sometimes it's really important just to hold it for a minute and just let it out slowly. And that lets the oxygen diffuse more efficiently across the membrane, and it helps relax you. It actually releases relaxing hormones, just taking a deep breath and slowly letting it out. So if you're feeling anxious, sometimes just deep breathing is enough to kind of get you back in control and not feeling so short of breath that comes with anxiety. Okay, so looking at the lungs are divided by connective tissue into different lobes, and then those lobes are divided further into bronchopulmonary segments, and each of those segments has its own airway and its own blood supply. So if a segment shuts down because of cancer or pneumonia, the vessels feeding that part of the lung will constrict. So we don't waste blood on an inefficient part of the lung. And the other more efficient parts of the lungs, the blood vessels going to those parts will dilate to make sure we're getting good gas exchange. It's called ventilation perfusion coupling. We'll talk more about that in advanced A&P. So if we look at, going back one more thing, looking at this bronchial tree, there's a change once we get to the lungs. So we had protective mechanisms in the upper airways, right? We had cilia, we have mucus, we have cartilage to hold it open. When we get down into the lowest of airways, the terminal bronchioles, there's no more cartilage. There's only smooth muscle to hold those airways open. There's very little cilia, very little mucus. But what do we see else inside those alveoli to keep things healthy? There's another cell, part of the immune system. Yeah, the macrophages. And okay, so like I said, we had these connective tissue divisions, which is nice. So people can get a whole lobe removed if they have lung cancer in a specific lobe, and they can be okay, and they can survive cancer. If it's isolated and it's not in the blood and it hasn't spread, people do have lung cancer and survive. There's different types of lung cancer. There's large cell lung cancer and small cell lung cancer. The small cell type is more dangerous and has a poorer outcome, again, linked to smoking. And the other number one cause of lung cancer is, do you know? If you're not a smoker or you're not even around smokers, you have no exposure to smoking or smokers, what? Asbestos can be one, especially with your older patients that dealt with a lot of that kind of stuff. Maybe they had construction jobs or they worked in industry where we didn't pay attention to asbestos. Definitely. So there's definitely environmental exposures through work. And another common one around here especially is radon. And a lot of people don't know about radon, and this is kind of a hot button for me because I worked with a young person that passed away, and likely cause was radon. So it was very sad, very, very sad. Person was in their 20s. and passed away from lung cancer, never exposed to cigarette smoke, but had a basement bedroom. So radon is in yep, it's in the soil. It's part of the rock in the soil, and it's a radioactive element that breaks. It starts as radium, which is a solid in the soil. And then as it decays, like radioactive substances do, it converts to a gas called radon. So in your basement, there's not a lot of air exchange, and that gas settles in the basement, and it's in the air. And people are inhaling that radon gas, and it's bouncing around in the lungs and doing damage to DNA and causing cancer. So if ever you buy a home, this is my big recommendation for everybody in here, if you buy a home, ask for a radon test. Make that part of your purchase agreement. Or if you already have a home and you don't know the radon status of your basement and you have a lot of people hanging out down there, get a radon test. They sell them at Home Depot. You can stick them in the basement, put them in the corner, make sure all the doors stay shut. You know, you don't have windows open and things. You let it sit for a couple days and you put it in a bag and you send it to the lab, and then they'll give you your results back. And I was really surprised. The house that I was living in, a farmhouse years ago, and I had a basement office and I had a kid's playroom down there, it had high radon levels. The lucky part is we didn't finish off that basement until the last year we lived there, so we weren't down there a whole lot. But again, if you're a kid and you're or a teenager and you're living in that basement bedroom for 5-6 years, you know, that can be risky for you. And I've had patients too that have had radon exposures, you know, elderly women that are like, I never smoked, how can I have cancer? And again, radon. So don't underestimate that. If you talk to realtors, they don't have a science background. And I've talked to realtors, oh, we want a radon test. Oh, you're sure? Yep, I'm positive. And then, oh, the radon test came back. It was what, I forget what the number is, but it was at the high end of normal. And, oh, it's within the range, the accepted range. And I said, no, that's unacceptable. Who says that that's the acceptable range? You know, because if you go to California, it's way low. So there is natural radon out in the air we breathe, which is significantly less than what we accept in our houses. So don't rely on the realtor to tell you that your radon is acceptable, because it's not. So when we bought our last house that I live in right now, it had a high radon level, and they were trying to talk us out of being worried about that. And I said, absolutely not. If we're going to finish the contract to purchase this home, I want a radon mitigation system as part of the agreement. The sellers have to install it, and they did. It was like a $2,000 piece of equipment, but they wanted to sell this house, and I didn't want to have radon. So, and I have 4 kids in my basement, fortunately. Some need to move out, but that's okay. They're in the basement. They could mess it up, and I don't have to look at it. But yeah, so it's a big pipe that runs through the center of your house. Or if you're ever going to build a house, we just had a conversation last week. We're looking at building a house, and I said, you know, do you install radon mitigation systems? No, not typically. Well, that's a must. We want a radon mitigation system installed. Okay, no problem. You know, but if you don't know this kind of stuff, you don't ask the questions, and you put yourself at risk. Okay, so like I said, that's a hot button for me because I personally witnessed someone who suffered the effects of radon. More than once. I've seen it more than once in the hospital setting. Okay, so ventilation then. We talked about that concept, the definition, movement of air in and out of the lungs, but what is the actual cause of the movement of air in and out of the lungs? So it has to do with volume and pressure. What drives, the driving force pushing air in and out of the lungs is pressure. So it's all about pressure. We need a pressure difference. So how do things flow? Just like we see in diffusion, high pressure to low pressure. If we increase the pressure on one side, whatever that gas is going to flow to the low pressure side, right? We all have experience with that. If I blow up a balloon, there's high pressure on the inside of that balloon. If I let the balloon go, it goes and the air flows out without any energy required. So the biggest thing we need to do in order to change pressure is to change the volume of the thorax. So we have muscles that control the size of the thorax for air, where the lungs are, the pleural cavities, right? We have the external intercostals that move the ribs up and down and out. So that's in charge of expanding that space and pulling on the pleura, stretching that space. And then we have the diaphragm. Now, a big thing that people get wrong when they haven't taken A&P is understanding that the diaphragm, when it contracts, it moves down. And that was your online worksheet for today, right? You had to kind of analyze and fill out that little table about ventilation. Study that table well for the exam. So when the diaphragm contracts, it moves down. So what would happen to my chest cavity then if the diaphragm contracts and moves down? What the volume gets bigger, yeah. So when the diaphragm contracts, the volume increases. What happens to pressure if I increase the space for those air particles? Decreases, because pressure is the force exerted on the walls of the container by particles in there. So if I increase the volume, there's less bouncing against the walls and pressure decreases. It's kind of like I use the term with the concept when I describe pressure is like taking a bunch of feral cats. You know what a feral cat is? A wild cat that has no experience with humans. They are just crazy. And I had to pick up some one time at a neighbor's garage, and we got them into this kennel, and they were so freaked out from being in a kennel. They're used to being wild, right? They were bouncing against the walls of this kennel. So obviously, if I had a bigger kennel, there'd be less bouncing off against the walls, right? Less pressure against the walls of the container. So external intercostals move out, diaphragm moves down, volume increases, pressure decreases inside the lungs, so we have a pressure difference. We have higher pressure outside the body compared to lower pressure in the lungs, so which way does air flow? Into or out of the lungs? Into the lungs. Then flows in until what? What stops all diffusion and movement of particles? Yeah, until we have equal pressure. In this case, not equal concentration, but equal pressure. So when the pressures are equal between the outside air and the lungs, then the airflow stops. Then the diaphragm relaxes, and when it relaxes, what direction does it move? Up. So what is that going to do to pressure and then the external intercostals are relaxing, so I'm bringing the ribs in. What happens to volume? What happens to pressure? Increases. Now I have high pressure inside the lungs compared to outside the lungs, so then air flows out. So which process is active? Which one requires muscles to contract? Inspiration, yeah. So what nerve stimulates the diaphragm to contract? Do you remember? Phrenic nerve. Remember the diaphragm and phrenic, P-H-R? So when the phrenic nerve has an action potential flowing to that diaphragm, that contracts and moves the diaphragm down. And then we had the intercostal nerves that serve the muscles over the chest, the external intercostals. When those contract, moves the ribs up and out. So inspiration is an active process. Expiration is just turning that off, inhibiting that action potential, and allowing everything to just relax and go back to its resting position. So air flows out until what? Equal pressure. Because do we want to blow all the air out of our lungs? What would happen to our alveoli if we just blew all the air out of our alveoli? Yeah, they would collapse. And then they would stick together, and we'd be in a world of hurt. So we have pressure changes that drive air movement. But what causes the pressure changes? What do we have to change first? Volume. So the key concept for this slide is volume has to increase first. It starts with, and what causes the volume change? Diaphragm and external intercostals. So if you put the steps in order of ventilation, it's muscles contract, volume decreases, pressure increases, air flows. And then we have to do the reverse of that. Muscles relax, volume decreases, pressure increases, air flows out in that case. So just know that order. Muscles, volume, pressure, flow. Airflow is the last thing that occurs. So there's a little animation here we can watch. Hopefully it's not been taken down. Okay, good. So here we can see the diaphragm contracted, the pressure inside the alveoli dropped, if we use the number 1 as our just reference number, it's less than 1. The barometric pressure outside the body is 0, so 0 to -1 is a decreased pressure, so air flows in until pressure increases, and they're equal. See how they're both 0? No more airflow. And then now watch, the diaphragm is going to relax, moves back up, volume is decreasing, pressure is increasing. So this value would be what then? Higher than the outside air, so +1. And air flows out until the pressure in there decreases due to the airflow going out. What value would we have to get here then? 0. So we use the value of 1 or 0 as just kind of a reference number. Because barometric pressure at sea level is 760 millimeters of mercury, right? But if I lived in Colorado, that pressure would be smaller. So it doesn't matter the actual number of the barometric pressure and the actual pressure inside the lungs. If we just use a simple number of 0 and 1, it's always going to be the same outside. So barometric pressure is always going to be 0. But at inspiration, when we're bringing air in, what does the pressure inside the alveoli have to be? Higher or lower? For air to go in? Lower. So then the P alveoli would be what again? What number is less than 0? -1. And then if air is going to flow out, pressure in the alveoli has to be higher, so then the pressure would be +1, right? So that's just a simple reference using, simple numbers of 0 and 1. Okay, so the pleura, those membranes, are really important for keeping the lungs intact and having them move with the chest wall. When we inhale and exhale, we want those lungs to follow the rib cage. So there is the parietal pleura that connects to the body wall, and there's the visceral pleura that connects to the lungs itself, and then there's some fluid in between there. And every time you breathe, that reduces the friction so your lungs aren't rubbing along the chest wall. And it also keeps those lungs stuck to the chest wall. Did you ever have a drink of something cold in the summertime and you set it on a glass table and you pick it up and it kind of sticks? Or you could even slide it and it kind of rolls and coasts across the top of the glass table. That's how the membranes work. So you've got the parietal and visceral pleura that are kind of stuck to each other because of water molecules. So the pleural fluid has a lot of water, and there's a cohesiveness of those water molecules that they stick together. And when you have two different membranes, we call that adhesion, but it's sticking to the membrane. But whether it's cohesion, adhesion is not as important as just understanding that it's water molecules, which that force that holds water molecules together, we call that surface tension. Surface tension. So the surface tension inside those membranes hold them together so they stick to the chest wall. So if I inhale and the lungs go out, the stickiness of the visceral to the parietal pleura, because of that pleural fluid, lungs go with it. If we penetrate that space, we lose that stickiness because the pressure in that space increases. So we have this pleural fluid in that space, and it's constantly drained by lymphatics. So if we have a space that we're not adding anything to it, but we're constantly taking away from it, what do you think that does to the pressure in there? Is pressure high or low? If I have a space with fluid and I'm constantly sucking fluid out, that would create a low pressure, yeah. So this is a space that always has a negative pressure. So if we're looking at numbers then, those simple numbers, 0, 1, what is it always going to be? -1, -1. And if we inhale, we have more of a pull. If I increase the volume of a space without adding anything to that space, what is that going to do to the pressure in there? If I increase the volume, what does that do to the pressure? Decrease the pressure. So sometimes that On an inhale, that pleural space can go from -1 to -2 even. It becomes more negative. And then when we exhale, it's back to -1. But it should never be positive, because if it's positive, the lungs and the body cavity no longer stick together. And what do we call that when the lungs move away from the body wall and are no longer inflated? Lung collapse. And the fancy name for lung collapse is called, it's at the bottom of your slide there in capital letters. What is that called? Atelectasis. Atelectasis. Kind of a strange word, but yeah. What?
I've never heard that term.
Yeah, you'll hear of it in healthcare for sure, because it's a big problem. So atelectasis is a lung collapse. So that can happen from surgery when we go in and penetrate the chest wall by doing surgery on the heart or on the lungs. We're breaking through that membrane and we're going to cause lung collapse. So how do we get that negative pressure, that negative suck, to get the lungs to reinflate or to prevent lung collapse when we do surgery? Do you know what we insert in the chest wall? Yeah, a chest tube. And that's a little box with a tube going from it into the chest wall, and it's set to a negative value, and that just removes fluid if they had surgery, or it just keeps a negative pressure if they have lung collapse. So it's called the chest tube. It's very painful because it goes right, in between the ribs, and the chest wall is very sensitive, so it's very painful. And patients with chest tubes often need a lot of pain coverage for medicine. So very important that we have negative pressure in that space. So let's take a look. This uses the number -5 for the pleural pressure. So it's just showing how negative it is compared to the other pressures that we talked about. So you can see when we inhale, see how the graph drops? It becomes more negative in the pleural space when we inhale, and then as we exhale, it becomes less negative, but it's always negative. Alveolar pressure, when we're inhaling, what happens? Initially it increases, then it decreases, then it increases, and then it's increasing as we exhale, and then it's dropping when we stop exhaling. So it's pressure changes that drive air movement. And again, what causes the pressure changes? We have to change the volume. Yeah, the volume. Okay, so all of these terms here on this table, or this slide, describe features of the lungs that allow it to move air in and out. So elastic recoil, think of it just as the stretchiness of the lungs. Just how well do they stretch? So recoil, like you've heard of, like a gun has recoil, right? When you shoot a gun, it kicks back at you. So you're trying to get it to come forward, but it kicks back. So if I stretch the lung and it snaps back, so if I inhale and the lungs get nice and big, and then when I turn off those muscles, right, the lung goes back down. So that elastic recoil is the ability of the lungs to move inward. So if we drew a picture of the lung and put these, here's one lung, if I just labeled these, an inward force is elastic recoil. Pleural pressure is, again, that negative pressure that allows the lungs to stick to the body wall. What direction does pleural pressure act on the lung? Because if we don't have it, what did I say the lungs do? Which way do they move? Inward or outward if I don't have pleural pressure? What? Inward. So pleural pressure helps keep the lungs expanded, right? So that acts outward. Compliance is the ability of the lungs to move with the thoracic wall. So compliance is kind of a mixture of, if we have good elastic recoil, the lungs can stretch and move outward with the lung. And compliance, if you think about compliant, non-compliant, right, is like, okay, come here, I want you to go with me. No, I'm not going. Then we would say, you're non-compliant, right? You're not going with who you're supposed to go with. So when the lungs don't move with the chest wall, we say that's reduced compliance. But if the lungs move really well with the chest wall, we call that increased compliance. People with emphysema have blown out alveoli. And because the alveoli are blown out, that affects anaphylactic recoil. Would you agree? If there's less simple squamous tissue because it's been damaged by chronic cigarette smoke, there's less alveoli, and we have these big holes in the lung, and the lungs actually get bigger. So will they move with the chest wall if they're bigger? Yes, they will, because there's less recoil, less ability to go inward. They only want to go outward. So people with emphysema have increased compliance, but it's not a good thing because they're stuck like that. We call that the barrel-shaped chest. If you know anybody with emphysema, they have like a really big chest because the lungs are huge. But if I have a stiff lung, or if I have a lung full of fluid because of pneumonia, there's a lot of surface tension, that's going to keep the lungs small. So you'd have reduced compliance if you had lung cancer, scarred lung from industrial exposures, or pneumonia because of fluid. So surface tension due to fluid, surface tension is going to act inward because that's what lines the alveoli, that cohesion among those water molecules. So compliance has to overcome recoil and surface tension to get our lungs to expand. So people with a stiff rib cage, as we age, we have our rib cage, the cartilages stiffen in our rib cage, so we have less ability to move our rib cage. So coughing is a problem when we get old. So if a person gets influenza from a young person who said, oh, I don't need that flu shot, if I get influenza, I can handle it. But then you bring that influenza to the bedside and give it to a patient that can't move their mucus, they're at risk for death because of that, because they just can't cough well when they have a stiff rib cage. So we'll pick up next time talking a little bit more about each of these factors.